Wake up, catch the vision, join the team. This is Pastor Reginald Johnston of My Father's House Christian Church right here in Fayetteville. We want you to wake up and join the team. Behold, how good and pleasant it is for brethren to dwell together in unity. It's good when we come together. We're one body, many parts. We desire that you wake up and join the team. It's good to be a part of Wake Up. Wake up, join the team. We will see you in Jesus' name. God bless you.
Welcome to Cape Fear Valley's Making Rounds Live, broadcasting and streaming live from the WIDU Community Room.
The WIDU Radio Network, WAGR in Lumberton, WIDU in Red Springs, WEWO in Laurinburg.
Making Rounds Live on 99.7 FM, 1600 AM.
We air every second and fourth Tuesday of the month.
Making Rounds Live.
The purpose of this show is to bring you information on health and wellness.
Here's the host of Making Rounds Live, Omega Jones.
And thank you so much, Ray. Welcome back to another edition of Cape Fear Valley Health's Making Rounds Live. I'm your host, Omega Jones. Today we are recognizing Brain Injury Awareness Month, and due to the subject matter we are discussing today, let me go ahead and put this disclaimer on out there. Remember that this broadcast is not intended for you to self-diagnose. This is for informational purposes only. If you may be suffering from something that we may discuss today, or you have a friend or a loved one that may be suffering from something that we may discuss today, I want you to find yourself a healthcare professional. Now, today we're discussing brain injuries and recovery. And brain injury, it can happen in many ways, from mild concussions to stroke to more severe traumatic injuries. Recovery, it often involves a team of specialists all working together to help patients regain that independence, rebuild confidence, and improve their overall quality of life. Today, joining us, we have Ms. Taylor Simpson. She is a speech language pathologist, and Ms. Rachel Farnham. She is a physical therapist, and they are both with Cape Fear Valley Health Rehabilitation Center. Now, during segment one, we're going to talk to Taylor about speech therapy and the important role it plays in recovery. Then during the second segment of the show, we're going to talk to Rachel about outpatient physical therapy and how patients continue to heal after they leave the hospital. So, ladies, Taylor, first we'll start with you. Welcome to Cape Fear Valley Health's Making Rounds Live.
Thank you.
Before we get started, tell us about you. What inspired you to become a speech language pathologist and work in this field out of all of the different fields you could work in medicine?
Yeah, so I'm Taylor. I'm from here, so born and raised, born at Cape Fear Valley Hospital. And I went to undergraduate at NC State, and then I got my master's at East Carolina University. And I wanted to go into speech pathology because I wanted something very maybe non-traditional, but working in healthcare, I always knew I wanted to help people, but I wanted to do something maybe not as well known. And I had a friend that was in a program, and after talking with her, doing a lot of shadowing, I decided that was the field that I wanted to go into. And I like it, and especially working with adults in the medical setting, just because I get to use a lot of critical thinking skills, and I'm also meeting people after very large life changes and trying to help them navigate that through the knowledge and experience that I have, and it can be really rewarding.
Let's talk about brain injury. What exactly is it, and how can it happen?
So for the purposes of this, an acquired brain injury is, it can be divided into two areas. So acquired meaning it came after birth and it's an insult to the brain in some form. So there's two different types. So there's a traumatic brain injury, and then there's non-traumatic brain injuries. So a traumatic brain injury is something such as there was an external force applied to the brain. So whether that be a fall, car accident, firearm wound, assault, those are the traumatic things. It's an external force on the brain. Then there's non-traumatic brain injuries, which are things such as strokes or having complications after a seizure, hypoxic events, meaning there was lots of oxygen to the brain. And so there are a lot of different types of, or ways you can acquire either a traumatic brain injury or a non-traumatic brain injury.
Levels of brain injury, are there different levels of severity?
Yeah, so there are definitely there are different ways that we classify it. I'd also like to point out that I am not a physician, so I'm not the one actually diagnosing the type or the severity, but I do have knowledge about how it comes about. So there are kind of three different ways that a physician might classify a brain injury using different things. One being the Glasgow Coma Scale. So it's a scale that they might administer like maybe straight after a brain injury in the field, and they're rating on a scale of 3 to 15. So a 3, a lower score, indicates lower level of consciousness, more severe injuries, whereas a score of a 13 to a 15 might indicate a more mild brain injury, so present, but maybe not as severe as someone that has no eye movement, no motor movement, no speech response to questions. So that's the Glasgow Coma Scale. Other ways that they might look at it is the duration of consciousness. So after an injury, so if it was a traumatic injury, such as being in a car accident and someone hitting their head, did the person lose consciousness? So were they out for 10 minutes, 30 minutes, 2 days, hours? So looking at the time that someone is unconscious is important to help us classify how severe an injury is. And then another area that I think is lesser known is, did someone experience post-traumatic amnesia? So this is the time after a brain injury in which someone is unable to form new memories. So in more severe cases, someone might be experiencing post-traumatic amnesia where they wouldn't probably know things like orientation information, such as where are they right now, who did they just have a conversation with, what time is it, things such as that. So if someone does experience post-traumatic amnesia, how long did that duration last? So someone could not experience it. It could be 10 minutes. It could be days. So a lot of times when patients end up with severe injuries on inpatient rehab, I'll have patients that experience post-traumatic amnesia for the full duration of their rehab stay. It really just depends. And then other things a doctor will do is take head imaging. So they might perform or order an MRI to be done, or a head CT scan to look at the extent of the injuries on imaging, and then where the insult occurred. So that actually gives Rachel and I a lot of good information when we're doing a chart view. We want to know where did the injury occur specifically in the brain, because it helps us with our assessment and diagnoses.
Ladies and gentlemen, we're talking with Ms. Taylor Simpson. She is a speech language pathologist with Cape Fear Valley Rehabilitation Center. This is Brain Injury Awareness Month, and that's our topic today. If you would like to join in on the conversation, you can give us a call at 910-483-6111, or you can leave a comment you can leave the question in the comments section of today's live stream on Facebook, and Lindsay will make sure that we get that question answered for you. Also, we're streaming live on YouTube, but Lindsay is only one person. She can't work both platforms at the same time. And finally, we want you to make sure that you share the broadcast. A lot of great information is going to be discussed today. Too much for you to try to be the middleman. So make sure you share the broadcast, and that way you can get the information and the right information to the people that may need it. We're in the middle of an interesting conversation with Ms. Taylor Simpson. She is a speech language pathologist with Cape Fear Valley's Rehabilitation Center. Taylor, let's talk about warning signs. What are the warning signs people need to watch out for after a head injury?
So things that you might be looking for are loss of consciousness, repeated vomiting, altered mental status, meaning confusion, is someone very confused about what's going on, and then not really coming out of that. Other things might be a severe or worsening headache, or slurred speech, seizures, things that are abnormal for the person. You would want to seek immediate medical attention.
All right. how can you mention the speech earlier? How can a brain injury impact someone's speech and communication?
Yeah, so that's actually a lesser known, the scope of what speech language pathologists do, I would say, are lesser known after a brain injury. I like to break it down into, or three, the most common areas I see after a brain injury are changes in someone's speech, someone's language, or someone's cognition. So for speech changes, this might look like someone has slurred speech. Maybe they're having difficulty coordinating their breathing for speaking, because every time we speak, we're exhaling as we do. They might have low vocal volume, rapid rate of speech, or really slow rate of speech, and those are differences, and we call that dysarthria. Language is a change to someone's ability to actually access their language. So the two different areas of language are someone's receptive language skills and expressive language skills. Receptive is what you understand. And so if someone's asking you to put your socks on, did you understand that that's what they wanted you to do? Or did you put your hat on, or did you do none of that? And those are things that, and I think we'll touch on that later, but things that are probably really hidden and it's not visible to a lot of other people, and that's where we come in to try and point these things out. Changes to someone's expressive language skills might look like inability to, or difficulty communicating their wants or their needs or ideas, word finding, using the right word for things appropriately. So it really can impact their ability to communicate their wants and their needs. The other area is cognition. So changes to someone's cognitive skills can happen after a brain injury. And the domains of cognition, they're actually, all of these things are overlapped. So we're using our cognitive processes all together at all times to do anything. So this can look like changes to someone's attention skills, changes to someone's memory skills, their ability to recall information, whether that's immediately or after some delay. Other things are changes to their visuospatial skills, which is your brain's ability to use your eyeballs to perceive information. So if you're driving a car, how far away is that car? If you're reading a book, are you seeing everything on the page? And then and one that I see really often is changes to someone's executive function skills. So executive functions is a fancy term for higher level cognitive skills. So things such as reasoning, cognitive flexibility, meaning being able to see things through different points of view. Organization or planning, can someone sequence steps to complete a task? And so those are higher level skills that may be hard to spot, but that's kind of our job, is to figure out what skills, if any, or all, or some, are being affected.
What about changes in someone's behavior or personality? Does that happen? And if it does, what should families understand about those changes?
Yeah, so unfortunately, changes to emotions and behavior after a brain injury is fairly common. And it can be very upsetting and a frustrating part of brain injury recovery. A lot of times what we'll see is sometimes someone goes from one extreme to another. So irritability, even agitation. Someone might have been really a steady, easygoing person before, and now they're really quick to anger, where that wasn't their personality prior. Other things you might also see are apathy, so being indifferent to things, being very flat in their affect is what we call it, but your emotions, so not really caring about what's going on around you, and that might be very different for family, but also consider it's very different for the person themselves experiencing that change. So I try to do a lot of family education on what they might be seeing, what they might expect to see, and understanding that it probably is going to fluctuate. That's the name of the game with brain injury, is that things fluctuate, and it can be really hard to kind of roll with those punches any given day. So just kind of having that understanding that that person is experiencing a change as well. And so it can be frustrating on all fronts, especially with the emotional changes.
Ladies and gentlemen, we're in the middle of a conversation with Ms. Taylor Simpson. She is a speech language pathologist with Cape Fear Valley's Rehabilitation Center. Our in-studio guest today on Making Rounds Live. Taylor, many people are surprised to learn that Speech therapy, well, you mentioned the cognitive skills. Let's go into the one thing that I didn't know about was the swallowing therapy. I didn't know that existed. So what exactly is that?
So that is a lesser known aspect of brain injury recovery, is that swallowing can be affected by brain injury. Any sort of neurologic injury can change someone's ability to swallow. And why that matters is because it can have a lot of clinical consequences, meaning it can be really not healthy for someone to have a poor swallow. So you've probably heard of when you've had the sensation of something goes down the wrong pipe. Okay, when you're swallowing. Well, we have two pipes that run really close together, and when we eat and drink, we want food to go into our esophagus, the one pipe, to our stomach. And someone with a brain injury may not, their body may not be doing that as well as our body, and what we say protecting our airway. So our airway is the other pipe that sits in it, and that leads to our lungs. Well, unfortunately, sometimes trouble with swallowing can result in something called aspiration pneumonia, which is an infection in the lungs where a foreign body, whether that be food, drink, even saliva that has bacteria in it, can happen. So one thing that we heavily encourage is oral care, so keeping a clean mouth can be helpful. But we do a lot of diagnostic work with swallowing after. So things that we can do is we might perform something called a bedside swallow to kind of look at what is someone presenting like just face to face, and then if we feel that there are a lot of heightened risk factors for maybe something is going the wrong way, we might do what we call objective imaging or an instrumental study where we can actually see on camera an x-ray swallow of where food and drink is going. Other things that we might do is some people are trained to do what's called a FEES or a fiber optic endoscopic swallow study, where they put a camera up someone or down someone's nose, but it's looking like a bird's eye view at your vocal, like your airway, and seeing whether or not food and drink is going in. So after we do the diagnostic piece of it, then we move to the treatment piece of it and kind of decide what treatment options the person may have. Some injuries are so severe to swallowing that maybe someone isn't safe clinically, from our point of view, safe to eat by mouth, or maybe it's really limited quantities, or maybe it results in us recommending like a modified texture or diet, meaning they might only be able to consume softer foods. So it can look like that. It can also look like result in malnutrition, so dehydration, and where that comes into play is if someone has, let's say, a wound. Well, someone that's malnourished is going to have really poor wound healing. So it can have a lot of clinical consequences, and we want to make sure we're identifying those and trying to minimize someone's health complications after the fact.
Taylor, can you give a family member or even a caregiver, what does a typical day look like at at Cape Fear's Rehabilitation Center?
So a patient or a family member can expect that the patient's one of their big goals is to attend daily therapy. So during the weekdays, the person would participate in both physical therapy and occupational therapy for sure. Speech therapy is not always indicated for everybody, so they may or may not do that, but it typically looks like a combined 3 hours of physical therapy and occupational therapy a day, broken up into morning and afternoon sessions. And then if they needed speech therapy, that would be an additional 30 minutes on top of that therapy schedule. We like to keep a schedule because with working with brain injury, something that can be helpful is keeping a routine. So we try to keep things as routine as possible, both for them and for us, and then trying to address what their goals are. That's the therapy side of it, but there's also the medical management side of it. So the physician will be visiting with the patient daily. Nursing will be present, so the person would have a nurse with them every day, and then there's nursing assistants. And then another aspect of it is coordination of care. So we have a case manager who is figuring out the person's discharge needs. So we're all working as a team to figure out, well, Inpatient rehab, estimated length of stay is anywhere from 10 to 14 days. Now, that doesn't mean it couldn't be less, and it doesn't mean it couldn't be more, but it's technically a short-term rehab. So there is what happens when someone leaves. So we all as a team are coming up with, well, what's the plan for when they leave? And the case manager is the one that's really facilitating the logistics of that. And we're lucky to have great case managers. But it might be that someone needs extra care. So maybe they have to go to a lower level skilled nursing facility where the person is still receiving nursing care, still receiving therapies. Or maybe the person goes home with home health. Or maybe they go to outpatient therapy with that's where Rachel is. So it kind of just depends. But we try really hard to work as a team to meet the patient's needs and their goals.
Taylor, before we go into our first break, what advice would you have for someone who's feeling discouraged early on? Because you mentioned emotion is a big part of this.
Yeah, I would first say to them that it is not uncommon and it's nothing that they should be ashamed about for feeling the shock or guilt or grieving the person they were prior to the brain injury. Same for the family. And that they're navigating new changes to their body, new changes to their physical abilities, new changes to perhaps their cognitive or communication abilities. And also recognizing that it's in an unfamiliar place. It's not, who wants to spend their time being in the hospital. It's not home with family all the time. So it can be scary and it can be very different, an experience that none of us have hopefully had to face. But I would say starting with the acknowledgement of it, but then moving to trying to celebrate small victories. So whatever that may look like for the person, and making sure that we're targeting our goals to being the thing that they want to work on, because ultimately the person with the injury has the say in what their goals are for their recovery. So I would say that, and then giving themselves grace, because it is that roller coaster. Things fluctuate very heavily, and each day could look very different. And so encouraging and educating patients and families on what recovery could look like and how it differs day to day.
And finally, this seems like a simple question, but folks need to know, how can we prevent brain injuries?
So that's a great question, and I kind of want to categorize it by the type of brain injury. Mm-hmm. So to prevent traumatic brain injuries, so think of the external force applied, things you want to do is making sure you wear your seatbelt in your car, making sure you wear your helmet. There are a lot of motorcyclists in this area. Unfortunately, I've seen a lot of traumatic brain injuries following motorcycle accidents. So making sure you are wearing your helmet, you are being a safe, conscious driver, you are falls are another leading cause of brain injury, traumatic brain injury, especially in older populations, 65 mm-hmm. and older. Trying to make sure your home is safe. So clearing walkways, trying to reduce fall risks is also really important. So that's for the traumatic brain injuries and prevention. To prevent a non-traumatic injury such as a stroke, that's the other population we see quite a bit of that are coming to inpatient rehab. Is the main thing I'd say is you want to talk with your doctor about limiting your risk factors. So things that increase your risk are high blood pressure, making sure you're managing that as needed. You also want to do things like eating a balanced diet. Sleep is very important and something that is not always taken seriously. And then also exercising as the person is able. But at the end of the day, talking with your doctor about what you can do specific to you to minimize your risks is the best thing I could recommend for you.
So basically, just make sure you keep a healthy lifestyle for the most part.
Yeah, and being a good advocate for yourself is another thing that I encourage patients and family members that I see to advocate for your care, and knowing I want to reduce my risks, and that's going to be a priority in my life, and making sure that you're speaking up for that.
Well, Taylor, this has been a great conversation. Thank you so much. I didn't get to all of the questions, but I really hope you'd come back so we can continue the conversation. But thank you for taking time out of your busy schedule to be with us today. Greatly appreciate this.
Absolutely. Thank you.
Now, ladies and gentlemen, up next, we're going to discover what happens once a brain injury patient is discharged from the hospital. Cape Fear Valley Health's Making Rounds Live. Make sure you stay close.
We'll be right back with more of Making Rounds Live.
Cape Fear Valley's Making Rounds Live.
Broadcasting and streaming live from the WIDU Community Room on 99.7 FM, 1600 AM.
The WIDU Radio Network.
Pastor E. Kenneth Wells, Locks Creek AME Zion Church. You're listening to Wake Up.
Gas prices have seen a dramatic increase in the last week. NC State University economics professor emeritus Mike Walden tells Spectrum News 1 there are a lot of reasons too. In a briefing today at the Pentagon, Defense Secretary Pete Hegseth said the U.S. is winning the war with Iran decisively and with brutal efficiency. Less than a week after the primary election, Republican U.S. Senate candidate Michael Whatley is continuing to campaign, appearing at a school in High Point with U.S. Secretary of Education Linda Mahan, who is promoting President Trump's administration's Education Freedom Tax Credit. Former Governor Roy Cooper says he's hitting the road and running for the U.S. Senate for the people of North Carolina. He also made a visit in the Triad yesterday. Oversight Committee on the state's Department of Health and Human Services is expected to receive updates on DHS audits from the state auditor. Mike Rayleigh, NCI News.
I'm Peter Killeen, WIDU Radio News. Mayor Mitch Colvin invites residents to the State of the City address set for tonight, 6:30 p.m. in the Council Chamber at City Hall, 433 Hay Street. During the address, the mayor will provide an update on the city's progress, highlight key achievements, and outline the priorities set by City Council for the year ahead. With nearly 100 days in office with the current City Council, the mayor will share where Council is headed and how their priorities are shaping decisions that impact residents across Fayetteville. The State of the City address is a free event open to the public. The address will also air live on faytv.net, Spectrum Channel 7, and on the Fay TV app, available on streaming devices. Cumberland and Hoke counties inviting residents to review and provide feedback on the draft Cumberland-Hoke Regional Hazard Mitigation Plan. It's a long-range plan designed to reduce risks from natural disasters and to strengthen community resilience. The plan outlines options and actions that people can take in terms of property and infrastructure. From WIDU Radio, I'm Peter Killeen.
This morning starting out pretty mild with the chance for a few stray showers. As we head into the afternoon, however, going to be very warm, partly cloudy, high temperatures in the low to mid 80s. Overnight clear to partly cloudy and warm once again. Temperatures first thing Wednesday morning in the low to mid 60s, setting the stage for another warm and breezy day. Highs in the low to mid 80s Wednesday afternoon. A cold front brings an increasing chance for rain and possibly storms on Thursday. I'm meteorologist Chris Michaels in the NCN Weather Center.
Wake up, catch the vision, join the team. This is Pastor Reginald Johnston of my Father's House Christian Church right here in Fayetteville. We want you to wake up and join the team. Behold, how good and pleasant it is for brethren to dwell together in unity. It's good when we come together. We're one body, many parts. We desire that you wake up and join the team. It's good to be a part of Wake Up. Wake up, join the team. We will see you in Jesus' name. God bless you.
Hi, I'm Cherie Sample Hughes, Chair for Women in Government. February is Rare Liver Disease Month. If you're feeling unusually tired, struggling with brain fog, or dealing with persistent itching or body pain, it may be due to liver disease. Fortunately, liver disease is diagnosed with the use of simple blood tests and can help be managed with the right care plan. Talk with your doctor about getting screened and the best steps for treatment. With the right care and support, there's a path forward. Find more at womeningovernment.org.
Hi, this is T.W. Campbell.
And I'm Patricia Campbell
of the Refuge Community Church, located at 2314 L.A. Downham Road here in the God Bless city of Fayetteville, North Carolina. You can reach us at area code 910-483-6477. We're here to invite you to our early morning service each Sunday morning beginning at 8:30 in the morning. Our prayer is at 6 o'clock, our intercessory prayer. Bible studies at 7 o'clock, which now is our Sunday school at night, and which we call the Word on Wednesday. Come and be a part of a growing community. In Jesus' name.
Amen.
God bless. This is Pastor McAllister, and we would love to be able to invite everyone to share tributes to our late Miss Sandy Cookman. We know many of you want to take time to pause to share with them. Therefore, what we're doing here at the WIDU radio station, we're opening up the phone lines starting on March the 9th through the 13th from 1 to 2 p.m., asking you to please call in, share some love, share a tribute to them. Again, Monday through Friday, March the 9th through the 13th from 1 to 2 p.m. Please call into the radio station 910-483-6111 or even stop by to share some love. They would love to hear from you. They want everybody to have an opportunity. So we are opening up the station and the phone lines starting Monday, March the 9th through the 13th, 1 to 2 p.m. Please call in, take a moment to share words of love, compliments, how you felt about this wonderful woman of God, and we know the family will appreciate it. God bless. Please share that word. Love you.
Hello, this is Kevin Wester of Destiny Real Estate, and you are listening to Wake Up.
This is Bishop Johnny Ray Jr. of the Churches of Worship Worldwide, Apostle J.A. McDonough, 2118 Owen Drive. And we are proud to be a part of the Wake Up. Come and join the team.
We now return to Making Rounds Live.
Cape Fear Valley's Making Rounds Live.
Broadcasting and streaming live on the WIDU network, 99.7 FM, 1600 AM. Here's Omega Jones.
Thank you so much. Welcome back to the second segment of Cape Fear Valley Health's Making Rounds Live. Before we introduce our next guest, don't forget that the Life After Stroke Support Group, they meet every third Wednesday of the month at 3 p.m. in the Cape Fear Valley Rehabilitation Center Physical Therapy Gym. Now, if you want more information, you remember Megan Dornan, she's been with us several times. You can give her a call at 910-615, I forgot that one, 7077. That's 910-615-7077 to get more information about the Life After Stroke Support Group. Now, ladies and gentlemen, let's move on to part two of today's broadcast. We're talking about what happens after a patient leaves the hospital and continues healing. Ladies and gentlemen, please welcome Miss Rachel Farnham. She is a physical therapist also at Cape Fear Valley Rehabilitation Center. Rachel, welcome to the broadcast.
Thank you so much.
Before we start talking about outpatient therapy, tell us about your background. What inspired you to become a physical therapist and work with brain injury patients?
Sure. So I'm originally from up north, Connecticut, but I've been here about a little over 10 years, working at the hospital since I moved down here. So I've gotten the blessing of being able to work in inpatient, acute care, outpatient therapy throughout those years and seeing different types of patients. I knew in high school I wanted to do something healthcare, kind of like Taylor had mentioned, but I didn't know exactly what. And I got the opportunity to shadow a bunch of different professionals, from doctors to nurses to PAs to PTs. And I chose our field because I like that we get to spend more time with patients and really kind of get them back to the things that are the most meaningful to them. So it definitely got me into the goal of getting into physical therapy. For neuro conditions, I got into that kind of along the way. My clinic at undergrad or grad school, Springfield College, had a clinic on site that treated a lot of patients, including a lot of patients with strokes. What? So I enjoyed working with them there. And then when I started in acute care, I got to rotate up to the floor where they had patients right after strokes. So got to experience that early side of it. And then now in outpatient neuro, have seen a lot of people with strokes, TBIs, concussions, dizziness, all those kind of issues. So,
if an inpatient is being discharged from rehab or the hospital, what determines whether outpatient rehab is recommended, and what changes in their care?
So they look first at like what the person's condition is that they're recovering from, whether they need outpatient orthopedic, more for backs, hips, knees, shoulders, that kind of pain, or if they're a neurological patient that has had a brain injury or stroke, are they more appropriate for outpatient neuro? The doctor will then send a referral and recommend that after their discharge. They decide if the patient, when they discharge from inpatient rehab, are they safe to be able to get to our outpatient clinic or not? If not, they may be a better candidate to go to a home health or have home health come to them and work with them. If they're able to get out of the house safely with family bringing them, then they might be best for outpatient neuro. And we have some different pieces of equipment that make it a little bit easier for us to sometimes challenge them on a higher level once they're at that point to be able to come to outpatient neuro. It does change a little bit from inpatient side. They get seen every day while they're there. For outpatient neuro, we have a little bit different goal. In inpatient, they're trying to get them as quickly as they can safely back to home. For outpatient, we want them to still keep improving, but our goal is to start to make the patient as much independent as possible and really teach them what they need to keep doing to keep seeing progress. So trying to really help them kind of empower them really to continue to see progress even well after therapy. So we'll see them typically 2 to 3 times a week, depends on the patient, and usually it's for 2 to 3 months. It can go a little bit less, it can go a little bit more depending on what the patient needs. So that is a difference from inpatient.
Do you have to be discharged from one of Cape Fear Valley's campuses to get the outpatient rehab at Cape Fear Valley's Rehabilitation Center?
No, you can. We've had many patients that have come from other facilities. They can come from any other rehab. Some of them haven't even had a lot of therapy. Maybe they went home and didn't get a lot right away. As long as their doctor sends a referral, they can come to outpatient neuro.
Ladies and gentlemen, Ms. Rachel Farnham, she is a physical therapist with Cape Fear Valley Rehabilitation Center as we recognize Brain Injury Awareness Month. Rachel, what are some of the most common physical challenges survivors face?
I think there's numbers of them, but definitely for some of them pain. They might have neuropathic pain that's kind of involved after a brain injury. They might have decreased endurance and fatigue. They've not only had a brain injury, but they've not been moving as much as they normally would have been moving, so they've kind of gotten their endurances down. They can have weakness. It can be one side of the body, especially if it's post-stroke. It could be global weakness that we're kind of dealing with to kind of strengthen them. Some of them can have dizziness, depending on where their stroke or brain injury has affected them, and that can make it very difficult for them to move, change positions, all of that safely. Many of them have decreased balance and increased risk for falls, so they're dealing on a fear of falling too. Yeah. So many times they're very fearful of that. Decreased coordination, unable to get their hands or their fingers where they need them to go, grabbing items, moving things, manipulating things, and sometimes even sensory issues. So vision issues can be a big one. They might have blurry or doubled vision. They could have issues feeling. Could be temperature, could be hot or cold items they can't tell, so their safety is a little bit decreased. It could just be light touch that they have a difficulty with, so all of those can be things that they're dealing with.
Let's talk about balance and fall risk concerns. How do you address that or those issues in outpatient therapy?
We do a lot working with patients with balance issues because a lot of them do come with whether it's mild or major issues with that. So we always do several, at least a few assessments of their balance when they come to us for evaluations. And we're looking to see how are they moving as far as how are all their systems that their brain uses to help them keep their balance working. So we look at their vision, their motor movements of their eyes. We look at their sensation. Can they feel well through their feet? We look at inner ear function. Is that helping with the brain to be able to use that information to keep their balance, along with how the brain itself is doing after that stroke or injury? And we try to train those specific things. If they're having issues controlling their balance at their ankles or their hips, or they can't step fast enough to catch their balance, then we'll work on those specific strategies and really practice them over and over again to make them safer and better. We also do a lot of assessing how well can they get up and down from the ground, because although we want to make every patient as low of a fall risk as we can, we know that at times there may be times that they either have to get up and down from the ground for something that they want to do, or that if they do fall, we don't want them to stay on the floor. So we would practice with them safely getting up and down from different surfaces and from the floor.
Rachel, now I know you can't put everyone on the same formula, but how do you measure progress?
So we measure very specifically. There's a lot of, we say, functional outcome measures. They're tests that have been specifically studied with therapists and with patients to be able to determine where their scores should lie for whether or not they're a fall risk or not, and are they showing improvement. So it compares, when they've done the studies with these tests, they've compared to that specific group of patients, whether they had a stroke or a TBI or Parkinson's, whatever it may be. And they've also sometimes can give identifying a range of what their age norm should be, like where they should be. So we take those tests and we use them at the initial eval, and then at least every 4 weeks we retest those same tests so that we can show progress and that they're improving with therapy.
Let's talk about, you mentioned earlier about getting people back to doing what they love to do. How do you help patients regain their strength, their coordination, their mobility?
We do a lot of different methods and use a lot of different equipment that kind of helps us with getting them back to what they want to do. Initially we form the goals based on what they want to do and what their goals are, what they need to be able to do at home. But we can use different equipment like tilt tables. We can use standing frames to kind of, especially for patients that are lower level and haven't been able to move very well without a lot of help, kind of start to get them upright again and on their feet, loading through their legs and strengthening their legs. We can use things like different modalities like E-stim, which is electrical stimulation. It's very specific, point-specific E-stim pads that we put on certain muscles to kind of help kind of kick in those muscles and make them start working again and kind of get those signals to the brain. So, and we have a functional E-stim bike that we can do that on several muscles to be able to get that whole motion that kind of carries over to walking and gait. We do have different equipment where we can start getting them walking again safely. We have a track system that's in the inpatient rehab area that we can harness people up safely and get them walking or do different balance challenges with them. We also have a body weight treadmill system that does the same thing. We can harness them and know that they're very safe, but start to work on their walking, their balance, their endurance, all of those things as well. We try to put patients into different positions to get specifically where they need to be strengthened. So we might have somebody laying down and doing some activities. We might try to get somebody on their hands and knees with some support to try to load through their hips and their arms. Sometimes we'll get them into tall kneeling and put something in front of them, but just all to work on their hip strength and their core strength, working all the way up their body. We do a lot of training with different devices, wheelchairs, canes, walkers, all of that to kind of get them back to moving better. We try to go down to, we say, the least restrictive device that we can. We try to get them to something that doesn't get as much in the way as possible, but still gives them that safety to keep them safe. And then we do other things where we try to work on their coordination, getting their feet to where they need them to go, getting over obstacles, that kind of thing.
Ladies and gentlemen, March is Brain Injury Awareness Month, and we have Rachel Farnham. She is a physical therapist in the studio today. She is with Cape Fear Valley's Rehabilitation Center. Now, Rachel, from a clinical standpoint, how do you determine when someone no longer needs outpatient therapy?
So we form initial goals at the very first evaluation, and then, like I said, every 4 weeks we'll retest those goals to see if we've arrived towards those goals. There's two things we always have to answer for the patient as far as, are they ready to discharge from us or do they still need more therapy? Is what we're providing still skilled? Is it something that now they can do safely at home with just family or caregiver with them, or is it something that they specifically need us to be close by to keep them safe and to set them up and to give them cues to kind of know how to do that activity? So that's the first thing. And then we also try to look, are they still changing? Most of the biggest progress after a brain injury or stroke is in the first 6 months. So if they've gone through the hospital and rehab, and let's say it's been a month or two into that, and then we do a few months with therapy, we're kind of getting closer to that 6 month where they might see a little bit of a plateau. So we kind of help use those to determine, do they still need therapy right now? If not, are they at a good point where they can discharge to a home exercise program or a community program, and then still touch base with us as they continue to heal and progress so that we can keep boosting them up one more level each time that we see them towards their goals.
What happens when patients start to feel better and they think that they can stop this therapy early? Why is it important for them to remain and continue that full course of treatment?
I would say that there's a lot of layers of recovery when you're coming from especially something as big as a stroke or a traumatic brain injury. So just for example, it's one thing to walk and just be able to walk from room to room. It's another thing to walk and be able to turn your head and follow and watch people as they're going by you. It's a whole other thing to have your grandkid tugging at your arm, trying to carry on a full conversation with you while you're walking and looking side to side. So every step that we see them improve in their mobility and what they're able to do, we try really hard to add more things to it the next time that we see them, because life has us multitasking and dual tasking all the time. So we try to do as much as we can to keep progressing them. So I would just say for them to really talk with their therapist and determine what they want to get back to and make sure that they've gone through all of those stages to getting back to safely moving.
If someone doesn't start therapy right away, is it ever too late to benefit from the therapy?
No, I think that, again, the biggest, fastest changes often occur within that first 3 to 6 months, up to that 6 months. But they've shown that after brain injury or stroke, you can still have improvements even years after the issue. So they definitely can still see improvements. There might be some areas that are more difficult to change. Sometimes getting hand movement and arm function or some of the cognitive aspects might be still things that they have to compensate for or kind of modify for, but they can still see improvements in different areas, and the brain is amazing how it can heal.
Let's talk to, for someone who is listening right now and they've had a mild concussion, they feel fine for the most part. Why should they consider getting evaluated?
So for concussion, especially if they haven't gotten back to normal within that first week to 2 weeks, they should probably still consider talking to their doctor about seeing a therapist that's specially trained to treat people post-concussion. Because there can still be little things, even if they don't feel like it's a big deal, things that PTs can assess, like are they getting anything that's causing dizziness? Are they having any vision motor issues? Do they have any neck issues that are still causing some issues? There are some good recommendations that a PT can give to kind of help boost and improve their recovery. They've also shown that aerobic exercise with good pacing has helped with brain healing. So just seeing that therapist, if you're not back to normal within that first week to 2, to just kind of have a full assessment and be able to get those recommendations would be helpful.
We talked about mental health and emotional challenges during the first segment. Do you see that the same thing during outpatient therapy?
Yes, definitely. It's definitely a challenge, just not only physically, but it's a challenge mentally and emotionally for them. It's easy to get discouraged. You're not where you used to be. You're not doing all the things that you wish you could do. You have family, you have grandkids, you have jobs that you want to get back to. So it can definitely be a challenge. I think kind of what they had mentioned before, finding a good support group around you, having good friends, good family. If you don't have that support group already, finding a support group that's local to you, getting a good care team, a good therapy team that's behind you that can, again, even if they're not with you nonstop, they're going to touch base with you along the way and keep encouraging you is all helpful.
Rachel, in recognition of Brain Injury Awareness Month, what message would you like for survivors and families to hear today?
So I would just say just to be encouraged, find a good team, like I said, around you that can support you. Know that you can continue to see improvements, even if they're not huge. Take every small change as a big success. And definitely having those people around you that help you to feel like you can continue to improve and get back to the things that you love to do.
And finally, before we close out this segment of our broadcast, what makes the rehabilitation team at Cape Fear Valley Health so unique?
I think it's very unique. It's very comprehensive. Again, I love that we get to work with speech, OT, physical therapy, that we're close to each other and able to, when we have the same patients, kind of discuss and work together to get them back as much as we possibly can. Having rotated through the different areas of our hospital, I can honestly say that each area has just a amazing team of individuals that really care for their patients. And that, I think, to me has been the biggest thing. So, and I think the resources of the hospital, knowing that there are places that they can help recommend that this is the next step for you. This is a community resource for you. This is a community support group that we have at the hospital. All of those things can be very helpful for our patients. So.
Ladies and gentlemen, please join me in thanking Miss Rachel Farnham with being with us today. Rachel, a lot of information. Thank you so much for taking time out of your schedule. And once again, Taylor, thank you for taking time out of your busy schedule to join us today as well. And as you heard, ladies and gentlemen, brain injuries, it can affect their speech, it can affect movement, memory, it can affect our daily lives. So if you have a loved one who may benefit from rehabilitation services at Cape Fear Valley Health, what I want you to do is speak with your provider, or you can visit the website, capefearvalley.com, and you can learn more there. Taylor, Rachel, thank you again, ladies, for being with us today. And ladies and gentlemen, before we close out, please allow me to share a personal moment with you. Last week, I received a phone call from Pastor Paul asking me, "Are you sitting down?" Now, although I had an idea of what he was about to tell me, I really and truly didn't want to hear it. Allow me to give you a little history that Wes and Sandy Cookman has with Omega Jones, because if you don't know, Sandy left us last week. In the late 80s, I think the early 90s, that's when I first met Wes and Sandy. They had started WIDU over on, oh my goodness, what's the name of that highway? I can't think of it right now. But the rock place is over there right now. And it was a little building over there. And I had just gotten into the Fayetteville market. And that was the first place that I did a radio show, was for Wes and Sandy Cookman and the WIDU radio network. Before then, they played secular music for about 30 years, and Wes went in and he changed the format to gospel. Well, in 2007, they launched Wake Up, and Wes was on air. He was talking about heavy-hitting community concerns, while Sandy, she was behind the scenes handling business. In 2010, Making Rounds Live came on the airwaves thanks to Wes and Sandy Cookman and WIDU. And they have supported Making Rounds Live since day one. Darvin wanted to bring a radio health journal for the African American community that focused on health, wellness, and concerns that we worry about. WIDU gave Darvin everything he needed to make sure this broadcast would be a success. And I understand that even after they got clapbacks from people in the streets for reasons that didn't involve this broadcast, Sandy was the one that called Darvin and told my husband, "We have your back." When you saw Wes, you saw Sandy. When you saw Sandy, you saw Wes. And after Darvin's passing, the WIDU radio network was right there, and they helped in phenomenal ways. Sandy called me in her office the day we returned back to broadcasting. She dried my tears, and she said, "Omega, we have your back now." And she has no idea how powerful that statement was. Sandy was my sister in Christ. She was my business confidant. She was my friend, and that woman of God will be missed. And finally, I want to ask you to please allow Wes time to mourn and heal. This is about his time. This is not about your time. So give Wes time to heal, because he is owed that. So, ladies and gentlemen, with continued support from WIDU, the WIDU Radio Network, our next broadcast will be Tuesday, March 24th. So for our producers, Lindsey Graham and Ray Thomas, and the hardworking team behind the scenes, I'm Omega Jones. This is why I waited to the end to do this. I'm Omega Jones. Thank you so much for watching and listening to Cape Fear Valley Health's Making Rounds Live.
Your station for inspiration and information. 1600 AM, 99.7 FM, WIDU1600.com. We are WIDU Fayetteville. We do radio. Follow us on Facebook at WIDU